The vibration didn't start in the air. It started in my teeth. I was standing at the medication cart outside Bay 11, 4 hours into a shift at Hargrove Memorial Hospital, counting out 500 milligram amoxicillin tablets with the same deliberate care I brought to everything I did with my hands. When I felt it, a low resonant tremor climbing through the floor and into my boots and up through my bad knee and settling finally in my back molars, where it sat like a tuning fork struck against bone. Not an earthquake. Not the fact. I had felt that frequency before, in the dirt of a courtyard in Ramadi in 2006, and I had learned then to pay attention to what it meant. But that was a long time ago, and I was just the limping nurse. So I kept counting the tablets. They called me slow. They called me a liability dressed in scrubs. They said I was one bad shift away from a workers' comp claim and that the hospital's insurance carrier had questions about my gait. Then, 12 United States Marines walked through the front doors of Hargrove Memorial at 11:43 on a Wednesday night, asking for Viper, and every last one of those opinions became irrelevant. Let me tell you what happened first. My name is May Decker. I am 41 years old. I walk with a pronounced limp on my right side, and I have worked the overnight rotation at Hargrove Memorial in Lynchburg, Virginia, for 14 months. I took the night rotation deliberately, and for the same reason I had taken every other deliberately inconspicuous position in the 3 years since I left the Navy. Nights are quieter, the scrutiny is lighter, and fewer people are watching at 2 in the morning when I take the extra 30 seconds to navigate a threshold that the daytime staff handles without thinking. I took the job that required the least visibility, and I performed it with a kind of care that only a person who has done harder things in worse conditions can bring to something that looks simple. The ER at night smelled like old coffee gone cold, and the specific acrid bite of industrial floor cleaner that never quite covered the blood underneath. It hummed and flickered under fluorescent tubes that management had been promising to replace since before I arrived. To the overnight staff, the ER was a gauntlet. To me, it was a waiting room with better lighting than most of the places I had actually waited. The night crew was 4 nurses, 2 residents, and a charge nurse named Patricia Hollis, who ran the overnight floor with the particular exhausted competence of a person who had stopped expecting help and started expecting endurance. She was good at her job. She had never once commented on my limp, which in 14 months of working together constituted, in my experience, a form of respect. The hospital's medical director was a different story. Dr. Raymond Scholl was not a surgeon. He was an administrator who held a medical degree the way some people hold a driver's license, as evidence of a credential earned years ago that had since been superseded by a different set of skills. In his case, the skills required to run the financials of a mid-sized regional hospital and look authoritative while doing it. He was 60, lean, silver-haired in a way that suggested a subscription to the right barber, and he wore bow ties, which told you something about a man if you thought about it long enough. He appeared on the overnight floor occasionally, always when something had generated paperwork he found inconvenient, and he moved through the space with the specific displeasure of a man who regarded medicine as an unfortunate operational requirement of the business he ran. He had taken an interest in me 6 weeks into my tenure. I had been moving between Bay 9 and Bay 10, chart in one hand, saline bag in the other, navigating the corridor at my pace, measured, deliberate. Never hurrying, because hurrying with my knee on a wet linoleum floor was a different kind of risk than people seemed to understand. When Scholl had come out of the administrative corridor and watched me for approximately 15 seconds before speaking. "Decker," he said. Not a greeting, a summons. I stopped. "I've been reviewing staffing performance metrics," he said. "The floor compliance data shows your transit times between bays are significantly above average." He paused. Significantly. I'm aware of my pace, I said. I'm sure you are. He looked at my right leg in the way that people who are trying to look like they aren't looking at something always look at it. A brief downward flick, recovered quickly. I want you to understand that this hospital has an obligation to its patients to ensure that its nursing staff can respond to emergent situations in a timely, I respond to emergent situations, I said, within an acceptable time frame. He clasped his hands in front of him, the gesture of a man who has rehearsed this conversation. I've asked Patricia to document any instances where your response time creates a clinical concern. I want you to be aware of that. I looked at him. Noted, I said. Also, he said, as if it were an afterthought, though it was not, the insurance carrier has flagged your file. In case of a slip and fall on premises, given your pre-existing condition, there are questions about liability that I'd like resolved with HR. He smiled. The smile of a man who believes he is being generous by informing you that he is building a case against you, just so you know where things stand. I knew where things stood. I had known where things stood for 14 months. I said nothing else and returned to Bay 9. The burns on my forearms, the ones that ran from my right wrist to my elbow in a pattern that was not consistent with any kitchen accident, though that was the explanation I gave when anyone asked, caught the light of the fluorescent tubes as I walked, and I pulled my sleeves down to the wrists and kept moving. I had earned those burns in Fallujah in 2006, when I was a Navy corpsman attached to 2nd Battalion, 4th Marines, and an Ide had taken apart a Humvee 6 feet to my left while I was working on a Marine with a penetrating chest wound. I had kept working on the Marine. I had not processed the burns until 40 minutes later, when the firefight was over and the adrenaline metabolized, and by then we were in an FOB and a corpsman I'd trained with had wrapped my arm and told me I was an idiot. He had said it with considerable affection. The Marine had lived. I still knew where he was. He sent me a Christmas card every year, and I sent one back, but that was not information for this corridor. This corridor was for counting amoxicillin tablets and monitoring IV lines and staying small, which was the choice I had made and the choice I was keeping. 3 weeks after the conversation with Scholl, he stopped me again. It was during the day shift overlap, the brief window when night crew and day staff shared the floor. Maximum personnel, maximum witnesses. He came through the administrative corridor with a woman from Human Resources at his shoulder, and he stopped in the middle of the nurses' station, and he said, loudly enough for every person within 20 feet to hear it, "Decker, I need to flag something for the record." I stopped at the cart. "Go ahead." Patricia logged a response time of 4 minutes and 11 seconds to Base 6 last Thursday during a code alert. He looked at the HR woman briefly, then back at me. "The protocol standard is 90 seconds. Bay 6 was on the far end of the floor," I said, "and the patient in Bay 6 was stable when I arrived. The presenting code was resolved by Dr. Winters before I reached the doorway." "The response time is the issue," Scholl said, "not the outcome this time." The last 2 words carried the freight of everything he intended. "I want this documented. I also want it on record that I have counseled Miss Decker on response time compliance on 2 prior occasions." He looked directly at me. "A 3rd instance will require a formal performance review." The nurses' station had gone quiet in the way a room goes quiet when something is happening that everyone is watching and no one is saying anything about. I looked at Scholl. I looked at the HR woman with her clipboard. I looked at Patricia Hollis, who was looking at the floor with the expression of a person absorbing something they cannot change. "Understood," I said. I turned back to the cart. My right knee ached with the specific persistent throb it always carried. My forearms were covered. My face was neutral. I had spent years making my face neutral in rooms where neutrality was the safest available option. What I did not say, what I had been choosing not to say for 14 months, every single day, through every hallway comment and every performance flag and every insurance liability conversation, was that I had been a Fleet Marine Force Corpsman, FMF qualified. The designation that means a Navy corpsman has been trained and certified to operate with Marine infantry units in combat. I had done 3 tours. I had kept 26 Marines alive across 2 deployments in the Anbar province, including 4 mass casualty events where the distinction between fast enough and not fast enough was the kind that ended careers and lives. I had been called Viper by the men I served, a call sign earned not for aggression, but for precision, for the way I moved through a casualty scenario with the specific, coiled efficiency of something that did not waste motion. I was not slow. I was deliberate. There is a difference, and the difference is measured in the people who are still breathing because you did not hurry past the thing that needed your hands for 1 more second. I kept this to myself. I had gotten very good at keeping things to myself. That was a Tuesday. The Wednesday that followed it changed everything. I came on shift at 11 p.m., and the floor was running quiet. A fractured wrist in Bay 8. A hypertensive crisis in Bay 10 that Patricia had already managed before I arrived. A respiratory case in Bay 12 that I picked up from the outgoing nurse and walked through twice to make sure the oxygen parameters were where they needed to be. The night was the color of institutional amber through the windows, the parking lot lights reflecting off low cloud cover, and the ER hummed and flickered in its usual register, and I moved between my bays with my usual deliberateness, and I thought about nothing except the work. At 11:38, my teeth started vibrating. I was at the medication cart. I went still. The frequency was lower than civilian aircraft, lower than the medevac helicopter that used the roof pad, lower than anything I had felt in this building in 14 months. Deep, rhythmic, transmitted through the concrete the way only one class of aircraft transmits through concrete. A sound that doesn't start as a sound at all, but as a physical fact, a pressure in the bones before it becomes something the ears can identify. CH-53E Super Stallion, or close to it. Multiple, the interblade interval was, I stopped myself. I pressed my hands flat on top of the medication cart. This is not yours, I told myself. You left that world. You made that choice. You are a night shift nurse counting amoxicillin tablets, and this is not. What is that sound? The overnight tech, a young man named Connor who had worked the night rotation for 3 months and still flinched at loud monitors, had his head tilted toward the ceiling. Helicopter, I said. That's not like any helicopter I've heard, he said. No. I said. It isn't. The monitors at the nurse's station activated on incoming notification, not the standard medevac flag but a priority code. A military transport designation that I had not seen on a civilian hospital board in 3 years, and that made the muscles in my forearms tighten beneath my sleeves. Patricia was already at the station. Multiple casualties, military transport, ETA, she read from the screen, then looked up. 2 minutes. This is not a standard intake. No, I said again. I had moved back to the wall without deciding to. My back was against the plaster beside the isolation cart, and my hands were in my pockets, and I was telling myself very clearly and very specifically, not here. You are Decker. You are the limping nurse. You have a performance review pending. You count tablets. You stay against this wall. You do not move. The wall. I pressed into it. I told myself to stay there. Then the doors opened. They came through in formation, not the jogging chaos of a civilian EMS drop, but a tactical entry. Perimeter first, stretcher second, the unconscious spatial discipline of people who have never stopped being where they are, even when they are somewhere else. 4 of them, with the stretcher. 4 more spreading through the entrance corridor. Behind them, a Marine in civilian clothes who was not trying to look civilian and was not succeeding. His bearing as legible as a rank insignia. His eyes already cataloging the room the way rooms are cataloged when the stakes of not knowing are too high. Behind him, 4 more. And then 2 more after that. 12 total. I counted without meaning to. The Marine in charge, I would later learn his name was Gunnery Sergeant Leon Pratt. 1st Special Forces Operational Detachment, Marine Raiders, walked through the center of the entrance corridor and stopped and looked at the room. He had the specific quality of presence that comes from having been responsible for the lives of the people around you for so long that it becomes structural. It is not aggression. It is not authority. It is weight. The kind that has been carried long enough to become posture. Soul had materialized from somewhere. He appeared at crises the way certain animals appear at weather changes, drawn by instinct toward situations that might require management. He stepped forward. "Sir, I need you to check your... We have a Marine down with a compromised airway," Pratt said. "Blunt force trauma to the throat, partial laryngeal fracture. He needs a surgical airway, or he dies in the next several minutes." He looked past Scholl the way you look past furniture. "Where is your trauma team?" Scholl opened his mouth. "Don't tell me you're the administrator," Pratt said. "Tell me where the trauma team is." Dr. Winters, the overnight attending, came through the bay doors at a half-run, already gowned. He was capable. I had watched him work for 14 months. And he was a genuinely skilled emergency physician. But I had also watched him manage airways, and what Pratt had just described was not an endotracheal intubation situation. A partial laryngeal fracture with compromised airway meant the standard tube wasn't going in. It meant a surgical approach, a cricothyrotomy, and it meant someone who had done one before, not someone who had read about one. I knew that before Winters reached the stretcher. I knew it the way you know things that your hands have done before your brain registers the memory. I pressed harder into the wall. "Not here. Not yours. You have a pending performance review. You walk too slowly. You are a liability. You stay on this?" Pratt scanned the room one more time. "Viper," he said. One word. Flat. Declarative, landing in the room the way a frequency lands, not a question, a signal, already on the channel and waiting for the response. The word meant nothing to anyone in that ER. It was not a name they knew. It was not a designation that appeared in any civilian hospital staffing record. Nobody looked around. Nobody answered. Nobody except the woman with her back against the wall beside the isolation cart, who stopped breathing for exactly 2 seconds. I was looking at the floor. Then, I was looking at my hands, my right arm, where the burns ran from wrist to elbow under the sleeve, the specific map of a night in Fallujah that I had been covering for 3 years and carrying for 19. My hands were not shaking. They were the stillest thing in the room. Pratt took 1 step forward. He had not found me yet, but he was finding me the way you find something you know is there, by looking for the stillness in a room full of motion. He looked at me. I looked back. "Viper," he said again, not broadcasting. Confirming, I pushed off the wall. I did not hurry. I walked my walk. The walk that had been logged and flagged and performance reviewed and held against me for 14 months. And in that walk, something that had been compressed into an unworkable shape for 3 years unfolded to its actual dimensions. Not larger, not faster. Aligned, the way a blade aligns when it's drawn from a sheath, not a change in the thing itself. Just the removal of what had been containing it. Shawl said something. I did not process it. Winters was at the stretcher. He had a laryngoscope in his hand and a look on his face that I recognized. The look of a competent physician who has encountered the boundary of his competence and knows it and is trying to decide what to do next. "Crick, Kit," I said. He looked at me. He needs a crick. The tube won't pass. I was already at the stretcher, already looking at the patient. Male, 30s. The specific mottled cyanosis of a man who was not moving enough air. Tracheal displacement already beginning. Every second a subtraction. I need a number 10 scalpel. A tracheal hook, a 6mm track tube, and a bag. Move. Nobody moved for exactly 1 second. Then Pratt said, from behind me, "Do what she says." The room moved. The scalpel was in my hand in 4 seconds. I found the cricothyroid membrane by palpation. The soft depression between the thyroid and cricoid cartilages. The landmark I had located in the dark in a Fallujah courtyard in 2006, with less light and more noise, and the understanding that the marine under my hands had approximately 90 seconds of viable oxygen. I stabilized the trachea with my left hand, middle finger and thumb, and made the horizontal incision with the same controlled depth I had been taught at Field Medical Training Battalion in 2004 and had practiced in the dirt of 2 countries and had not performed in a civilian setting until this moment. Tracheal hook, dilation, tube insertion, 6 millimeters, advancing with the bevel facing down, rotating 90 degrees, inflating the cuff. I attached the bag. I squeezed once, watching the chest. It rose. Both sides. Symmetrical, equal, bilateral breath sounds. I said, without. Connor, the overnight tech, had materialized at my right shoulder and had a stethoscope ready before I asked. He had been watching my hands and not my face, and he placed the earpieces without hesitation. Bilateral, confirmed. The monitor above the stretcher. Someone had connected him in the last 90 seconds. The oxygen saturation moving from the 70s into the 80s and then across the 90s as I watched. Each number a thing that had not existed 15 seconds ago and existed now because of the specific geography of a membrane and a blade and the particular muscle memory of a woman who had been filed in the system as a slip and fall liability. I stepped back from the stretcher. I stripped the gloves. I held my right hand steady, and I looked at it, and I thought of my corpsman instructor at Field Medical, who had told me in 2004 that the hands remember what the brain forgets under pressure, and that the job of training was to put enough into the hands that pressure could never take it back. He had been right. It had never come back. Pratt was standing 2 feet away. He had been watching my hands the same way. His face had not changed. It was the face of a man who had been looking for something and had found it exactly where he expected it to be. "She was the best corpsman I ever saw in the field," he said to the room. To no one. To everyone. His voice was the same register it had been since he walked through the door. I looked for her for 6 months. Winters was securing the tube. His hands were steady. He did not look at me with any particular expression, just the focused neutrality of a physician who has absorbed new information and is continuing to do his job, which was exactly right. Scholl was at the nurse's station. He had his arms crossed and his bow tie was slightly off-center, and he had the expression of a man who had just watched the entire architecture of his professional judgment collapse in the space of a single procedure. Pratt turned fully to face the room. He pulled a folded document from his jacket, a printed record, something that had been prepared before tonight, and he read from it without particular ceremony, the way you read a fact. Petty Officer First Class May Decker, United States Navy. Fleet Marine Force Corpsman, FF qualified. 3 combat deployments with 2nd Battalion, 4th Marines, Anbar Province, Iraq, Ramadi, 2005, Fallujah, 2006 and 2007. 26 Marines recovered under fire, including 4 mass casualty events. Navy Cross 2007, Combat Action Ribbon. Call sign Viper. He lowered the document. Honorably discharged 2010 after line of duty injuries sustained during 3rd deployment. 3 years post-discharge service as trauma nurse, Bethesda Naval Medical Center. He looked at Scholl. She's been counting your amoxicillin tablets for 14 months. Scholl said nothing. There was nothing adequate. Pratt set the document on the nurse's station counter. Then he turned back to face me, and what happened next happened the way it always happens when it is real, without preparation, without announcement, without anything except the motion itself. His right hand came up, clean and straight. And the 11 Marines behind him, every one of them, came to attention in the same breath. The sound of their gears settling in the movement, a sound that had no business in a hospital hallway in Lynchburg, Virginia, and that I had not heard in 11 years, and that hit me in the chest like something I had been waiting for without knowing I was waiting. 12 salutes. In a row. I stood in my scrubs, in my limping body, in my covered arms, and I came to attention. The motion still lived in my spine exactly where it had always lived, and I raised my hand and I returned it. It took approximately 2 seconds. In those 2 seconds, I was everything I had ever been at the same time. Connor had both hands over his mouth. Patricia Hollis had her eyes closed and her chin up, the expression of a woman receiving something she considers overdue. The overnight resident had gone completely still. Scholl was looking at the counter. Pratt lowered his hand. He looked at me for 1 moment longer. "I'm sorry it took this long to find you," he said. "You found me," I said. He nodded. He turned back to his Marine, and the organized choreography of field-trained personnel took over the patient transfer, and the room began moving again in the specific way that rooms begin moving after something has shifted in them that will not shift back. I walked back to the medication cart outside bed. My right knee ached from the hip to the ankle, which it would do until I died, or until medicine advanced to a point where it could undo what a courtyard in Fallujah had done to it, whichever came first. The fluorescent tubes above the cart buzzed and flickered in their usual register. The night smelled like old coffee and floor cleaner, and underneath that, the copper trace of blood that never entirely left an ER regardless of how many times you cleaned it. I opened the top drawer. I counted the remaining amoxicillin tablets and noted the shortfall on my clipboard, the way I always did, the way I would do tomorrow night, and the night after that, if the nights continued to be mine. Scholl was gone by the time I looked up. His HR document was still on the nurse's station counter. Patricia Hollis picked it up, looked at it for exactly 3 seconds, and set it in the recycling tray without comment. She looked across the floor at me. She did not say anything. She did not need to. The work is its own record. It always has been. I have never needed a room to know what I am. I needed the room to need what I had, and tonight it had, and now the night could go back to being what it was. Quiet, fluorescent lit, mine, still here, still whole. If May's story hit you somewhere you didn't expect, hit that like button and share this with someone who needs to hear it today. Subscribe to the channel. These are the stories of the quiet ones, the ones who showed up every day without a word, carrying more than anyone around them knew. Drop your city in the comments. I want to see how far this one reaches.